This is Health Sciences Update. I'm Doug Nadvornick. WSU Health Sciences has a strong research program in addictions and mental health. The Spokane campus is home to the Program of Excellence in Addictions Research, or PEAR for short. PEAR, as we talk today, has a budget of about $14 million and more than 30 investigators. Its faculty members work with people who have addictions to alcohol and opioid and other substances. One of those researchers joins us today. Dr. Michael McDonell is an associate professor in the Elson Floyd College of Medicine. He's also the director of Behavioral Health Innovation, and he joins us now. Welcome, Dr. McDonell.
Thanks for having me.
So let's get a little of your background before we get into all the acronyms and all the things you're involved in.
So you mentioned PEAR, so I'm a faculty member at PEAR, and that means a lot to me because I come from the apple capital of the world, Wenatchee, Washington. So I grew up in Wenatchee. I went to Gonzaga as an undergrad, and then I was fortunate enough to be able to pursue my PhD in clinical psychology here at WSU. And I think outside of the nursing program, I think I was probably one of the first PhD students to graduate from WSU and be up in Spokane. And so the place has changed a lot. We had 2 buildings, I think, when I was here. And when I left, and now coming back after being at the University of Washington for 12 years, it's really exciting to be part of a new College of Medicine and a growing health sciences campus.
So what did you do at the U?
So at the University of Washington, I was an associate professor in the Department of Psychiatry and Behavioral Science. And I did, for the most part, the same thing that I'm doing here at WSU. Most of my work was focused on research to develop new interventions for people with addictions and mental health problems. I also had an active clinical caseload where I was in a number of different clinics treating people with serious mental illness and with addictions.
So you were juggling a lot of balls in the air. What are your particular professional interests specifically?
So my interests are really in sort of how do we bring positive or strength-based interventions to addiction treatment and to mental health treatment. So much of addiction treatment, for instance, like alcohol treatment, has a history of sort of either being based on sort of moral interventions or has been highly involved the criminal justice system. And so it's been kind of a punitive system that's changing, and some of us are really excited to change that. And our work is really around sort of bringing positive, strength-based interventions. And so my work is focused in that area, in addition to doing similar things with folks who have serious mental health problems. And also I was trained clinically as a child psychologist, so I'm still near and dear to my heart, still working with kids. And I was part of a foster care clinic over in Harborview, and really working with kids who have been traumatized and sort of helping them get their lives back together and helping families reunite and move on with their lives.
So what brought you from the U back to this campus here in Spokane?
So I think one thing that brought me back here was, there's a number of personal things. Spokane's changed a lot since I left. We can get to work in 6 minutes instead of 2 hours. That's exciting. And I think really it was I wanted to be a part of the growing health sciences campus, and really our group, which is called the iREACH, or the Initiative for Research and Education to Advance Community Health, which is a group that I'm part of. We were recruited here to sort of help start more public health research. But I haven't gone far from WSU because I've worked with Dr. John Roll and other folks in PEAR for my entire career. So it's wonderful to come back and actually be down the hall or just across the street from some of the folks that I've worked with.
And what does it mean to be associated with a College of Medicine, this new College of Medicine?
I think it's exciting. I think, coming from a large College of Medicine to a new College of Medicine is exciting. There's a number of novel ways that we can really help train physicians in particular around behavioral health. As a lot of people probably are aware, opiate addiction and the opiate epidemic we're struggling with, that is a unique and a profound challenge for physicians. So being able to be on the ground when we could train these young physicians on how to use opiates wisely. What are the other alternatives to pain management that we can pursue? And so really the idea to be able to work with them at an early age on early in their career and sort of how to intervene around behavioral health issues is something I'm excited about.
But it's also teaching those doctors in rural areas who don't have specialists clustered around them to deal with that. Are you involved with that at all?
So I haven't been. That's one area that we've really talked a lot about. I think my work has been mostly with American Indian and Alaska Native tribes who face a lot of those rural challenges. And so what we see there is sort of just a lack of access to providers and the struggle to find providers that are not only competent but also know the community and can understand the cultural issues. And I think that really applies as well to other rural communities, not just Native communities. And so I think that is a big piece of sort of what the College of Medicine is looking to develop. And I think we're excited about some possibilities around that. Rural areas have been differentially impacted in a negative way by this opiate epidemic. So, and that really is true in our work that we've done sort of with consultation or just meeting docs around the state. We hear a lot about sort of, I don't know what to do. I want to help, but I'm stretched by my resources. I know what to do initially, but I don't have that backup to sort of support me. So I know we have colleagues at the University of Washington who are working on this problem, and I know we're very motivated to help support rural doctors.
So what was your interest in working with Native people in Alaska, natives and?
So like, again, generally sort of, I really want our work to be helping communities that struggle in terms of dealing with, they have limited resources, they have limited financial resources, limited, professional resources. And so a lot of my work had been working with people who have serious mental illness in addition to their addiction. So I was approached by Deidre Buchwald, who's the director of iREACH, and she and her colleagues do a lot of work in American Indian, Alaska Native communities. And she basically said to me, we've been working on heart disease, we've been working with communities on diabetes prevention, but one area that we haven't done anything to help in is alcohol addiction. And so that's sort of, the work kind of came to me, and it's been an amazing learning experience because I've had to learn a lot and learn it quickly, and it's been, and learn from a place of humility. And so, I've learned amazing things, like a lot of people don't know that American Indians and Alaska Natives have the lowest rate of alcohol abuse, they have the highest rate of abstinence, so they're the most likely to not use at all. But for whatever reason, folks who do use, who are in many of these communities, really struggle with alcohol addiction. So we're hoping to, again, use simple and sort of low-intensity interventions that are feasible to help Alaska Native and American Indian communities deal with alcoholism.
So let's talk about some of those low impact, I think is what you just said. What are some of the tools that you use in working with these people to try to get them off of alcohol?
So for folks who are suffering from addiction, and particularly alcohol abuse, where my work mostly focuses, is an intervention that we've used, and Dr. John Roll here was one of the developers, called Contingency Management. And Contingency Management is an intervention, and it's helpful to sort of think about it in a way that's sort of the opposite of how we deal with addiction in the criminal justice system. So in the criminal justice system, if I have a problem with alcohol and I've gotten a DUI, one thing I'm probably going to have to do is I'm going to have to submit urine tests. So they're going to test my urine for drugs. They're going to test me for alcohol. And if it comes up positive if I use, they're going to put me in jail. Or I'm going to have to pay a fine. Or I'm going to get a sanction. Or if my kids are involved in child protection, I'm going to lose custody of my kids. So we just do the opposite of that. So in our this intervention called Contingency Management, it's also called motivational incentives. That's a better way to talk about it, really. What we do is we offer people rewards when they haven't used. So instead of giving them a sanction or punishing them when they have used, we're rewarding them when they haven't. And so what we found is that we can give people a small amount of reward, and really they'll choose the reward over the drug. And so our group is really the first group to find an alcohol urine test where we can detect use for long enough to make it feasible to do this intervention. And so it's a really fun intervention because you see people who are struggling, who are new to recovery, who want to stop, but they just don't have that motivation on a day-to-day basis to keep going. And so these prizes just give them that little extra push that they need sort of to keep it going.
But let's talk about the typical meeting. So you've got one of your clients comes in and he meets the therapist. So how would a visit go?
So typically the person comes in and we give them a urine cup, and they go submit a urine sample, and then they walk back down, and we can test that urine sample in about as little as 5 minutes to as long as 15 minutes. And so we hang out, we just sort of talk, chat, and see how things are going. And then when that test comes back, if it's negative, if they haven't used, then they get to draw from this prize bucket. And this is one way that we sort of try to make it more exciting for people. And so they reach in, and there's a bunch of chips in this bucket, and there's about 500 of them. And half of them say, "Good job," which means just keep up the good work, keep trying. And then the other half have a prize amount associated with them. So they either say small, medium, or small, large, or jumbo. And you have the best chance of getting a small prize, and that's about $1 prize. So there are little things that are sort of going to be helpful for recovery. So for people who are homeless and or just got into housing, they've been homeless for a while, they might need shampoo, they might need soap, they might need socks, they might need basic sort of simple clothing items. So, they're mostly things that you would get at the dollar store, at Target or Walmart. And so you have about an 8% chance of getting one of those. And then you have about a 7% chance of pulling a token that says large on it. And that's a $20 prize, and people get really excited about that. And so that's mostly gift cards to about any place you can imagine, along with prizes like inexpensive MP3 players or other sort of, George Foreman grills are very popular. I shouldn't be doing product placement, but the grills are really popular, again, for people who might be in a housing situation where they don't have access to cooking, to a stove, and so they really find that to be something exciting. And then we have a 1 out of 500 chance of getting something that's called a bonus prize, and that is something that's $100 or so in value. So that could be $100 in gift cards, so that really is there to sort of get people excited. So when people pull for these prize tokens, the more samples the more they're abstinent, the longer they're abstinent, the more samples or more times they get to pull from that bucket. So when a person comes as new to recovery, they might get to draw in that bucket 3 times. Maybe they get a prize. But if they've been abstinent for about 12 weeks, which is the length of the intervention, they might be walking away with 2 big bags full of stuff. So we want people to learn that just in real life, the longer you make good choices, effective choices, the more you're going to get rewarded.
Okay, so you mentioned 12 weeks as the length of the program. What happens after the 12 weeks? Do you continue to monitor them?
So for the 12 weeks in our studies, we continue to follow people just to see if there's an effect of the intervention after 12 weeks. But the prizes stop at 12 weeks. We've talked a lot about sort of ways to keep it going, but what we know is that this is part of the debate, but what we know in our studies is that people who have these alcohol and drug addiction, when we stop, we see an effect of the intervention for 3 months. So they follow up and they come back. But what we really are hoping is that in that 3 months, that those prizes are getting us a time where people are starting to choose abstinence and get these positive kudos, sort of get these rewards for staying sober, and then they're seeking out other opportunities that are rewarding in their life. So they might come back in contact with their kids. They might go and visit their family more. They might get into housing and they've been homeless. And so there's going to be other rewards that are going to keep motivating them to stay abstinent after that.
So some people are going to call these bribes. Are there moral questions, ethical questions regarding this? And what do you think about that?
Yeah, no, it's a question we get a lot. So I think, we're all being bribed. One basic way to look at it is we're all being bribed. We're being paid to show up to work. We have reinforcers in our lives. And so we actually are doing some studies where we're trying to reward people not with tangible things, but with sort of their values. So a person might blow into a breathalyzer and they get a text of a picture of their daughter because they told us that their daughter was one reason they wanted to stop using. So we're looking into those things because those are ultimately even less costly than the prizes. But what we really know is that we don't have to give people a lot of money. In fact, we know if we give people a lot of money to change their behavior, it won't work. They will be bribed. What we're doing is offering people a small amount of money. The total cost for these prizes is anywhere from $200 to $300 for 12 weeks. And so we're offering people a very small amount of money, and it's contingent on their abstinence. So if we know that if we offer them a lot more, $500 per time, that really is they're going to attribute their behavior to that reward and not to their own personal choice. So we want to give people a little extra bump in their motivation, and that's really important to people who are new in recovery.
Now I'm curious, do you think it would work with people who had more money, people who weren't of the ethnic classes that are traditionally a little bit less off? Does that make any difference in how the results would be, you think?
That's a good question. It's another common question we get. There's science in other fields that is looking into sort of these kind of individual differences, we call them. And I really think it's more an individual difference. So I know people who are very well off who will do anything for 50 cents. They'll fill out a survey, whereas other people will say, no, I'm not interested. So I think there's some individual differences that are at play. And we're really interested in sort of finding a personalized approach to these rewards. But for the most part, you actually, many of us who are watching have probably encountered these incentives in our lives now. When you fill out a health survey for your health insurer and you write, or you exercise, or you can document that you exercised, or that you'll get a free gym membership. So these incentives are starting to move now from a drug addiction and other areas of behavioral health into mainstream healthcare, and insurers particularly are interested in them. So I think we're finding that you might have to adjust the amount that people are given, but really we find that this intervention works for people who are poor, people who are wealthy, and again, most people, because of their addiction, often by the time they get to my clinic or the time they get to one of our studies, they might have been very wealthy, but they've lost a lot of their material possessions because of their addiction.
So in learning all this, do you think this is becoming more of a mainstream treatment for alcoholism?
I think that I would like to say it is. For alcoholism, it's very new. For other drugs, we've done hundreds of studies that have shown that this works, and it's probably the most effective way to get people to stop using outside of opiate replacement therapy for people who have opiate addiction. Yeah, but the problem is that it's not a talk therapy. It's not something where I can fill out a billing sheet and get reimbursed for it as a provider, and it's not a medication. So again, I can't get reimbursed for it. So we're really hoping with the Accountable Care Act that this would be an opportunity for us to use interventions like this. The Veterans Administration is the one large group who's using this intervention, and that's because they have to pay for all care for a veteran. And so if a person's hospitalized as a veteran, they're going to take on that care. If a person has to come to a primary care doctor appointment to talk about their addiction, they're going to have to pay for that. So in those kind of contexts, like group health or Kaiser Permanente or what we call a capitated system, this intervention makes a lot of sense. But for the most part, that's limited how widely spread this intervention has been.
Is it significantly cheaper than some of the traditional forms?
Definitely. I think we look at two things when we think about whether or not an intervention should or might be implemented in the real world. There's really three things. One, is it feasible? And we really I can hire and train almost anyone to do this intervention. You have to be able to use urine tests, and you have to be able to give out the rewards. And you have to be a positive person. And so that's fairly easy to do. The second part is that you have to be able to pay for it. And so you have to show it's cost effective. So we've done studies with colleagues here in the HPA department, Health Policy Administration Department, to show that this intervention is cost effective. So one example of that is in Seattle. Our first study was using this prize treatment to target cocaine use in people who have serious mental illness. And what we found is that not only did it help them reduce their drug use, but the group that got the prizes had only 14 days total in the hospital for 6 months. Whereas the group that didn't get the prizes had 150, I think 8 days in the hospital. So each one of those days back when we did that study was costing the state, or taxpayers, it was costing us about $800 a day. It was costing the hospital more, but that's what we were paying for it. And so you can see how these prizes really cost $200 to $300, and you can see how that prize cost would be easily offset by that. So I think that's another thing that sort of drives the cost effectiveness of this. It's a very cost effective intervention. It's feasible, and people like it. The other thing is people really, really like to be part of this intervention. When we ask people, why did you like being in the study, or why did you like the intervention, typically what they say is, they don't say anything about the prizes. They say, we like you guys. You guys are great. You guys are so positive. You think, thanks for building me up. I don't get many pats on the back, especially when I'm trying my best, and this is really great to get that kind of feedback.
So can you tell when people walk in for the first time who this is going to work best with and who it's not going to work well with?
It's a really great question. So the field of medicine is moving towards, the big push in medicine is moving towards personalized medicine, which is exactly that, which is, can we give a genetic test to somebody, and can we tell, is this intervention going to work for them or not? And what we're learning, and this is some of the research we're hoping to pursue pending getting the funding to do it, is really we can identify with this alcohol urine test that I was talking about. We can tell who's going to respond. Based on the level of that urine test, I can tell for the most part who's going to respond to this prize-based intervention, who's not. And so we're able to now do that, and we're hoping to do more studies to verify that that's really true, because we found that in the study we just finished in Seattle. So we're hoping to get more funding to really be able to pursue that, to develop sort of a personalized approach where some people might receive more of the rewards. We might reward people for cutting down their drinking instead of just saying you need to stop, because that's a big challenge for a lot of people. And a lot of people just aren't interested in stopping their drinking. They might be able to they might be interested in cutting down to maybe a healthier level, or a level where they can function better and be healthier. But so that's sort of where we're going, is trying to figure out who is going to respond to this intervention, and then tailoring it or matching it to the right person.
So instead of going a whole 12 weeks, you might, after 2 or 3 weeks, you might say, this isn't going to work. We know it's not going to work for you. Let's not waste your time.
Yeah, exactly. Yeah, and that's what we want, is especially for people who are new to recovery, and this is sort of a big problem in addiction treatment, just like any other health problem, is that when people feel like their intervention isn't working, the treatment isn't working, they quit. And so that is exactly what we're interested in, is how do we find the right treatment for the right person at the right time, because that's the key to recovery.
I'm curious as to whether or not, the best advertising is word of mouth. Do you get word of mouth advertising from the people who participate in your, and then get their friends and others who come in and say, you know, I'd like to be part of this too?
Yes, definitely. That's a big deal. Once we get going, in fact, the first study we did in Seattle was the only study I've ever finished early because we had such a great word of mouth in the community. In our native work, that's been a huge deal, is sort of how does this become known in the community? How do we reach whole families that are struggling with this issue? How do we reach people through social media? Because that's been a new change, a recent change to sort of how we find people and how people know about our work. But yeah, the word of mouth is a big deal. It's part of really how we get folks. And the thing that's sort of one example of that is a woman who was in one of our first studies, and she started bringing home prizes. She was using cocaine, and she started bringing home prizes to her family members, and they all used cocaine too. And so she started bringing these prizes home, and they're, where did you get these prizes from? And she said, well, I got them from this study, and they didn't sign up for the study, but they stopped using cocaine around her because they wanted her to get these prizes, and they wanted to support her. So even folks who weren't interested in stopping themselves were interested in supporting someone who wanted to stop. And I think the last time we saw her, she's one of the folks featured in our video. The last time we saw her, she had a couple years of being abstinent since the study was over.
Wow, interesting stuff. So let's shift gears to another area of focus. You're evaluating a program to help young people with psychosis. Tell us a little bit about that and what you're hoping to learn.
Sure. So psychosis is a problem that affects about 1 to 3% of Americans.
And what is it?
And so, great question. So psychosis is a problem where you hear or see things that aren't there, or usually they go together. And you have thoughts that are just not based in reality. So some people would call those delusions. So you have thoughts that just really are outside of reality. You have experiences that are not based in reality. So as a result, you start to lose touch with reality. About 1% of people will go on to develop what's called schizophrenia, which is a chronic version of psychosis that lasts throughout most people's lives. And so what we've done in the mental health system is, the important piece of this, sorry, take a step backwards, is that most people develop psychosis in adolescence and young adulthood. And that's just this extremely important developmental period for young people, where they're learning to become their own, individuate, they're learning to become themselves, they're going to college, they're developing relationships for the first time. All these amazing things are sort of happening at that time. And so what happens is, as you develop psychosis, those things sort of fall away. You can't succeed in school anymore. You have to leave school. You pull away from a lot of your relationships. And so what that can lead to then is that if we don't intervene at that time, when the illness first starts, it leads to all these long-term consequences. So people with psychosis have historically gone on to develop long-term disabilities. They've gone on to develop a lot of health problems. In fact, people with psychosis have a life expectancy that's 20 years shorter than you or I. And so this is just not okay. So there's been an amazing movement in the United States and in Europe, but a great movement in the United States that's involved researchers, clinicians, family members, people with psychosis, and Congress, which is fantastic, to really develop, test, and now implement treatments where we identify kids as soon as they're developed psychosis, and then we give them an intensive intervention that's developmentally appropriate, and really try to get their symptoms under control and get them back to school as fast as possible, get them back to their relationships and to their family as soon as possible, get them back to work as soon as possible. And what we're seeing in the studies that we've been doing are that these kids have better quality of life, decreased symptoms, and they're getting back to their lives, which is really exciting. And so Washington has developed a program called New Journeys, which is a program that is implementing a lot of these evidence-based, kind of an intervention. And we're implementing it right now in 3 sites, in Yakima, in Thurston County and Olympia, and then also in South Seattle. And these are pilot sites. We're really trying to figure out how we're going to get this intervention to work practically in our system of care here, because our system of care is typically, most people who are receiving care for serious mental illness, for psychosis, are in their 30s and 40s. So it's a new experience for a lot of clinicians to work with really young people who have psychosis, and to work in a very different way with them. So our role is to partner with the Washington State, the state government, as well as colleagues at University of Washington, and our part here is really leading the evaluation. So it's an exciting project. There's a lot of positive energy around it, and it's really, this is really, I think, the wave of the future for how we treat mental illness.
So what's a typical intervention for somebody with psychosis? There's behavioral stuff where you talk with them, talk therapy, plus pharmaceutical stuff. What's involved in that?
So typically the first line for most people with psychosis, the first thing is a really great assessment. So if you're worried about someone who you think might have these experiences, it's really important to get them a thorough assessment, because they may be often people who are using drugs or alcohol might experience similar symptoms, and it might not be of chronic psychosis. That might stop when they stop using things like marijuana or other drugs. People might also have a health problem that's leading to this, or they might have also experienced trauma in their lives, and that might lead to experiences that sort of look like psychosis. So before we start a program like this, we really want to make sure we have the right diagnosis. So after that's happened, then what we really know is for the first line treatment is really two things. One is medications. Antipsychotic medications are pretty effective. They really help those voices and those delusional thoughts. And for almost about half of people, they really have a positive response to those medications. The other thing that we know is extremely effective is psychoeducation. So it's teaching that consumer or that person who has psychosis about their illness, because psychosis is a self-management. Once you're on that medication, you really have to work with your providers to manage the illness, to know when you're starting to experience symptoms, to recognize that and to do something about it sooner rather than later, because part of psychosis is that as you get sicker, you start to lose your insight, and you start to not realize that you have a problem. So the other big component to that is psychoeducation for the family. And Dennis Dick, who's my mentor from graduate school and one of the leading researchers in this field, helped develop some of these what we call family psychoeducation interventions. And so that's the other big component to this is sort of how do we educate families on how to help their young person, how to react to things, how do they differentiate between what's normal adolescent behavior and what's a symptom of mental illness. And then we have other supports like helping kids, vocational services that we know will help kids get back to school and back to work. And other things like occupational therapy, which we know are very helpful, and speech and language therapy, or help with sort of learning issues that kids are struggling with.
So we've talked about two areas. Are there any other areas of research that you're working on that you want to talk about?
So I think we have a number of different research projects that we're hoping to start. The first episode, psychosis, is something that's really interesting. We're really hoping to actually take some of our interventions around these prize-based interventions, and instead of using them to treat folks who are 40 and who have suffered from mental illness for 20 years and addiction for 20 years, we know that the prizes work for them. Wow, wouldn't it be great if we could do that with them when they were 20, when they first started drinking, or we can catch them before they even started drinking. So we're very interested in that. Another area that's obviously a hot issue and an important topic in Washington State is marijuana. So we are fortunate enough to receive one of the WSU seed grants, which I think is a great name for a marijuana project, but a grant really to look at and start to develop a research infrastructure and research projects around the impact of marijuana on health. So we're looking at how marijuana impacts alcohol and drug treatment. So clinicians are often faced with this dilemma of sort of, how do I deal with marijuana? Maybe this person's here for cocaine problems, but they also smoke marijuana. Do I need to target that, or do I not? Do I need to treat that, or do I not? So we've got a number of projects where we're looking at that. Some of my colleagues in nursing are looking at sort of options for schools for when kids now get into trouble for marijuana. What do we do? How do we handle that? And looking at new innovative strategies for really supporting kids outside of the sort of typical way that schools might be able to respond.
So when Washington voters decided to make recreational marijuana use legal, how did that change the way researchers look at it? Did it give them more opportunities?
It's a good question. There's a lot of issues because it's a federal issue, it's not just a state issue. From a research perspective, the funding for marijuana, there's a lot of interest at a federal level and sort of as the natural experiment that's been happening across the country around decriminalization. But and I think it's also microclimate. So in Seattle, already before this law passed, if you were caught with marijuana, the sanctions against you were going to be relatively small. Whereas in other communities, that might not be the case. So I think that there's been a lot of really interesting things that we could study. But I do think that the things that we're worried about are, does this change risk behavior, especially for kids at risk? So for marijuana does increase your risk of psychosis. If you're a person who has the genetic predisposition for psychosis, if you have family members who have suffered from that problem and you use marijuana, we know that that could be one thing that leads to you developing psychosis. We don't think it's a cause, we think it's a trigger. And so we're interested in sort of seeing how young people's opinions about marijuana have changed. And we're definitely seeing nationally an increase in marijuana use and sort of a decrease to flattening of alcohol use. And so we're interested to see if what's the cost benefit of that, and really as marijuana is becoming more and more available, what's the health risk, and is there a health benefit? So there's a lot of some of these are controversial issues. People have strong opinions about them, but really we're interested in sort of using science to untangle this natural experiment.
Well, thanks for telling us about your work. Appreciate
Thank
it.
you.
Dr. Michael McDonell is an associate professor in the Elson S. Floyd College of Medicine. Health Sciences Update is a production of WSU Health Sciences TV. I'm Doug Nadvornick.